In this video, we'll be showing GATT for severe pigment dispersion after a laser peripheral iridotomy. The patient had the laser done about a month ago for a suspicion of a narrow angle by a referring physician, and pressures were riding in the mid to high 30s despite maximal medical treatment and oral acetazolamide. So when we had examined the patient, the angles were fairly open except for the area where the iridotomy was done, which was nasally. We had some focal PAS, and we were seeing a lot of pigment in the angle, and as we see here on the capsule as well. So there was a significant amount of pigment that was dispersed after the peripheral iridotomy, that the pressure wasn't reducing despite topical treatments. And so we decided to do the cataract surgery, as well as a goniotomy and a viscodilation. And so we proceeded first off with the cataract surgery, and then we're going to release here the PAS that is focal at the area of the previous iridotomy. We're going to use the eye track here to also do some viscodilation at the time of insertion of the probe. And we're seeing here that the iris is very friable, and we're just slowly teasing it away from the trabecular meshwork. And we see how much pigment there is in this angle here, with a significant Sampalesi line. And so we start things off by creating a small little goniotomy incision with a 20 gauge MVR blade. And we're going to depress the posterior lip here to expose that back wall of Schlemm's canal. We see that whitish sheen, and we inject some OVD there to help insert our eye track device. And then we grab it with a pair of micro tires, and we slowly advance it in the canal. And while we're advancing, we're injecting some viscoelastic. In this case, we used some Helon GV. And we're slowly advancing. We're seeing nicely the angle here, and sporadically we're going to turn off the microscope lights in order to better see our probe, ensuring that we're in the proper space. We're seeing here that we're advancing quite nicely. We're almost halfway done. And then once we get all the way to the other opposite side, we're going to proceed with the goniotomy portion, where we're going to pull the eye track out from the canal. We see it's all the way through here. And at this stage, we're going to grasp our eye track and pull it out through the main incision. And we're going to re-grasp in order to get as much of the eye track out. And this is a bit of a tricky move here, to be able to pull it out without getting it to escape from the canal without doing the goniotomy. So here we got about 180 degrees that's done. And then we're going to inject some viscoelastic here to show the cleft that we just created. And we see the back wall there of Schlemm's canal quite nicely here. And we're hoping that this will help decrease the pressure in this patient that had a significant IOP spike due to the pigment dispersion. We're going to put some air in the anterior chamber, leave a little bit of viscoelastic to avoid some heme reflux, hydrate our incisions, and ensure that there are no leaks. Thanks for tuning in.